what I will do is talk about two examples of subtypes being targets of drug development. You're going to hear later from Andy about some of his work that's really led to a lot of interest in some of the kappa antagonists in MDD with anhedonia. Today, I'm going to talk about two subtypes. One, anxious distress of MDD, and the other, delusional features. This is just a disclosure. I will say something about Corcept, a company co-founded a number of years ago, interested in glucocorticoid antagonists, and I'll say something about Sage, company I've been doing some consulting with now about on MDD and also anxious depression. So here are some of the subtypes that are out there potentially, really based on the monikers of anhedonia, anxiety, distress, etc. And as I said before, Andy's going to talk about anhedonia, and you've heard already a bunch about the epidemiology of anxiety and depression, as well as irritability and depression, and you'll hear from Manish about some of his studies. I'm going to talk first about anxious depression, and then talk about delusional features. So Maurice said it's about 60% of the people in his study have significant anxiety in the context of depression, and there are two kind of large-scale trials, one STAR-D and the other iSpot. STAR-D had multiple phases where they started all individuals on citalopram, and then followed up on with either crossing people over to new meds or adding meds to the citalopram if they didn't respond, and there were multiple phases. And in this study, which was nearly 3,000 subjects, there were 53% of them had significant anxiety. What was interesting in this study was when they looked at the remission rate in phase 1 to citalopram, they had significantly lower remission rates in the anxious group, 22%, compared to about 33% in the non-anxious group. And that's for remission. And for response, it was 42% versus 53%. The time to response was slower. And there were more side effects in the individuals who had significant anxious distress. And here you can see the data in terms of the remission rates, 22% in the anxiety group and 33%. And you can see here the response rates, 42 versus 53. When they looked at the next phases, one either in phase 2, switching or augmenting, they found that this anxious group continued to not be non-responsive. Here you have very low response rates here to switching to bupropion, 6% versus 28% in the non-anxious group. Switching to sertraline from citalopram, 23% for the non-anxious versus 5%, and similarly for venlafaxine. So even in going into phase 2, these patients didn't respond. And this non-response continues. What this STAR-D did not do is to test two commonly used strategies for patients with major depression and anxiety. One is the addition of a sedative hypnotic, such as a benzodiazepine, or the other is the addition of a atypical antipsychotic, particularly one that is more sedating, such as quetiapine or olanzapine. Now, in the iSpot study, and this was a study, wave 1 was 1,000 subjects. I was involved with helping set this up. with Evian Gordon and Lee Williams, who now is a professor at Stanford, formerly at Sydney, Australia. This was a multi-center study that was international, in contrast to the US. It included South Africa, Australia, and Europe, as well as the US. We were cited at the US. And looking at the DAS anxiety subscale, we found that the individuals who had higher anxiety tended to show lower remission rates for escitalopram, sertraline, or venlafaxine. The subjects were randomized to one of these three treatments. When we accounted for depression severity or drug side effects, we still found this robust prediction. And 42% of the sample, little lower than in the STAR-D, had an anxious subtype. When you look at the responses to the different treatments, looking at across the DAS, what you find is that in the overall group, the three drugs tended to be more antidepressant than they tended to be anxiolytic. But there was still some effect on anxiety from these three drugs, but it was much reduced compared to the antidepressant effect overall. This slide just shows you each point here is between 20 and 60 subjects of the 1,000. And looking at the DAS anxiety score on the x-axis and the QIDS remission percentage on the y-axis, the individuals with the higher anxiety score have much lower remission rates. And so the anxious group not only has lower remission rates, but quantitatively higher anxiety in the overall group in the 1,000 subjects is associated with lower remission rates. The highest remission rates seen here on the y-axis at around 40% is seen in the individuals who have either no anxiety or extremely low anxiety. So anxious distress, anxiety, predictor of bad response to antidepressants. Now, as I've said, there are different combinations that have been looked at. A combination of benzodiazepine with antidepressants, a combination of atypical antipsychotics, atypical alone, some data on mirtazapine, particularly in the elderly from our group, and the use of neurosteroids. But almost all of these are post hoc. So most of these are post hoc analyses of a larger sample study, such as iSpot or STAR-D, but looking post hoc at the effect of the anxiety. Just to give you a few examples, though, of results and suggestions of effect, this is an analysis of Papakostas did with a study of Mauricio Fava led, looking at fluoxetine alone versus fluoxetine combination with clonazepam, a benzodiazepine Klonopin used for sleep and anxiety. And they found that the remission rates were much higher in the patients who received the hypnotic, 33% compared to 9.7%. So this fully fits what we just heard in the previous presentation about a hypnotic or like benzodiazepine or hypnotic being associated with better outcome in terms of suicidality. Quetiapine XR has been studied in major depression as a monotherapy as well as an add-on. And in the high anxiety group, and individuals who also had anxiety total scores on the HAM-A of 20, the 300 milligram dose separated very nicely from placebo, but the 150 milligram dose did not. Had almost a 3-point lower improvement in terms of their MADRS score. In low anxious group, both 150 and 300 milligrams appear to be effective. So 300 milligrams of quetiapine seems to have an antidepressant effect, an anxiolytic effect. In the brexpiprazole trials, a post hoc analysis done by Roger McIntyre, looking at 2 milligrams plus antidepressants as usual, and 3 milligrams antidepressants against placebo plus antidepressants, showed a robustly significant improvement overall in MDD in patients who received brexpiprazole add-on compared to placebo add-on. So we've got already some suggestions that in non-delusional major depression with anxiety, that brexpiprazole and quetiapine have efficacy. This is the post hoc analysis done on the cariprazine trials looking at MDD and at 1.5 milligrams, and placebo caused a 7.8 improvement compared to 9.1, and there was a significant effects on depression with a low dose cariprazine. So enough suggestions that either benzodiazepine or a hypnotic said more sedating, but not only more sedating, antipsychotic, second generation antipsychotic would be helpful in patients with MDD with comorbid anxiety. So, but no prospective data. And there are very little prospective data on what to do. There is now one trial that has, in fact, built in a prospective analysis, and that is for zuranolone. Now, the slide shows you the GABA system with the benzodiazepine GABA receptor and the insert, and a benzodiazepine binding site with subsites, and benzodiazepines, if you remember, bind to that site, cause a cascade of influx of chloride, which then depolarizes the GABA receptor. But there are thought to be other, there are lots of drugs that will bind to GABA, but maybe not at the benzodiazepine site. You see this with anticonvulsants such as valproic acid, divalproex. You see it with potentially with alcohol, sometimes with the neurosteroids, thought to be extrasynaptic in terms of the GABAergic effect. And there's been a lot of interest in developing these compounds for a variety of uses, particularly for postpartum depression as well as for major depression. So brexanolone and now zuranolone. Brexanolone is essentially allopregnanolone, which is a progesterone derivative, is a neurosteroid. In postpartum depression, there is thought to be a relative deficit of neurosteroid levels after parturition. Brexanolone intravenously was approved for postpartum depression, but now there is a follow-on oral formulation, zuranolone, which has now been approved for postpartum depression, will be marketed soon. It has been studied and filed for rapid and for major depression, but it was turned down by the FDA. The major side effects are sedation and dizziness. Now, we reported at ACMP last year at a puzzle with Andy Zeiss and Charlie Demeroff and myself, a combined data analysis of 3 zuranolone studies, 30 milligrams, 20 and 30 and 50 milligrams. And these have been given these acronyms, mountain study, a waterfall study, that MDD with significant anxiety was found in about half the patients in these 3 trials, about 1,000 patients, and half, in fact, had significant anxiety. And we did the combined data analysis of looking at zuranolone 30 and 50 milligrams versus placebo. And what we found was that in the patients with MDD with elevated anxiety, giving zuranolone for 2 weeks and then looking at response at day 15, you found nice separation in the the depressed patients of zuranolone from placebo at day 3. And it continued out to day 15, even though the patients only got treated for, it was stopped 24 hours before. And this was highly significant. Still very large scale trial. So the p-values are quite robust, even though the difference is only 2.3. But when you look at the individuals without elevated anxiety, you get significant differences between zuranolone and placebo, but they're smaller, but they are statistically significant. Again, this was a retrospective analysis of these data, not prospectively done. And here you can see the combined CFB HAM-A score in people with anxiety, significant anxiety is about 2 points, and without anxiety, the anxiety effect is obviously smaller, but you would expect that given the baseline measures. Now, the last study, though, that has been press released but not yet published is, although now it has just been published in Neuropsychopharmacology, I think this last week, looked at zuranolone plus an antidepressant versus an antidepressant plus placebo in MDD, and treatment for 14 days, and they looked at a response at 3 days, and then they looked at the response blended from day 3 to day 15. Day 15 itself wasn't significant, but significant differences were seen between the groups, particularly in patients with anxious symptoms. So this was now done prospectively. This is the first prospective look at a drug that could be effective in MDD with significant anxiety. And here they saw significant differences in both the anxious and the non-anxious group. And this was declared prospectively. So we will see more and more attempts at developing trials for patients, drugs for patients with MDD with anxiety. There are a number of problems with this kind of approach, and Andy, I think, alluded to this before about what scales to use. How do you measure anxiety? Is it the HAM-A? Is it something else? What happens if do you have to develop the drug for MDD overall and then a secondary look at MDD with anxiety? Can you just develop a drug for MDD with anxiety? Should you then do a larger study with MDD overall? MDD with anxiety is the primary, and then say you have a secondary analysis for MDD without anxiety. And what happens if one makes and not the other? So all of these things I think are somewhat confusing for the FDA in terms of how to kind of structure these studies. And it's similarly going to be the case for all these carve-outs. You've heard already from Andy about anhedonia. It's going to be that way for insomnia with MDD. What about cognitive deficits with MDD? We've got lots of issues about that. Now, the first time I think people really looked at a subtype prospectively for the FDA was our work in major depression with psychotic features. And this was looking at developing a glucocorticoid antagonist for rapid relief of the psychotic symptoms in MDD. And I'll take you through the rationale, what the data showed, et cetera. But this was easy to make that argument. And the reason it's easier to make that argument is because 20, 30 years ago, Sandy Glassman showed pretty nicely that MDD with psychotic features tended to be poorly responsive to tricyclic antidepressants, and instead required either ECT or the combination of antipsychotics with the tricyclics. And so almost all studies in MDD have carved out individuals with psychotic features because of thought to be a lack of efficacy just in certainly monoaminergic antidepressants alone. So the kinds of symptoms that you have, psychotic features, delusions of guilt, delusions of deserved punishment, nihilistic delusions, I'm impoverished, I've lost everything, somatic delusions, I have cancer, I'm dying, delusions of impoverishment, and hallucinations. They're typically auditory when they occur, but they only occur in about a third of the individuals. This is one of the early papers that Maurice O'Hyan and I did. We were very interested in his original European database of 19,000 subjects in 5 European countries. And we noted a current prevalence rate of non-psychotic major depression of 2.0% and a current prevalence of delusional depression of 0.4%. So this turned out to be about 18.5%. The disorder is, the diagnosis is frequently missed. Patients hide their delusions. They think that you're going to think they're crazy, because probably people will. So they don't really underscore them. They often will underscore them after they're better and tell you, boy, I had this crazy thought and didn't want to tell people. And so we published this in the American Journal just over 20 years ago, Maurice. Just to give you a sense, this affects all sorts of ages. It is common in the elderly, but not limited to that. This is the suicide note. These people are highly suicidal, from Virginia Woolf. Dearest, I feel certain that I'm going mad again. I feel we can't go through another of these terrible times, and I shan't recover this time. I begin to hear voices, and I can't concentrate. So I'm doing what seems the best thing to do. And a sad outcome often occurs. Now, we got into this largely because we were studying the hypothalamic pituitary adrenal axis and the dexamethasone suppression test. And just to remind folks, the hypothalamic pituitary adrenal axis includes the hypothalamus, which secretes corticotropin releasing factor or hormone, stimulates the pituitary to stimulate the adrenal gland through ACTH. The adrenal gland feeds back to the pituitary to downregulate it, as well as to the hypothalamus. In patients, you can test this by giving a synthetic glucocorticoid, dexamethasone, and if you do that, you should in fact suppress the HPA axis. The body will react to it and suppress cortisol production, except depressed people often do not suppress. Now, what happens though with glucocorticoids is they have enormous effects outside the HPA axis. They regulate all sorts of gene transcription outside of the HPA axis, particularly in the amygdala, and at times the gene transcription is opposite to that in the HPA axis. So it's an important system that regulates about 20% of the genes in the body. If you give dexamethasone at 11 o'clock, Barney Carroll made this observation. Here we see in the controls, most patients will suppress. The suppression values around 5 micrograms per DL or lower. In this sample that we did at McLean Hospital years ago, we saw 1 out of 31 non-suppressed. But when we looked at major depression, hospitalized people with major depression, we found much higher rates of non-suppression. And when we looked at the subtypes within the individuals whose values were above 10, 70% of these, 80% of them had delusions, and everyone above 15, which is enormously high when you're thinking, most people are around 1 or 2 post dexamethasone. Everyone above 15 was delusional. And so you had this test that could be a pretty good sensitive test for delusional depression, more so than for melancholia. And that was one of the problems, I think, with Barney Carroll's assertion that it's just melancholia that really is what you're picking up. And it was highly specific to it. But there have been now multiple meta or combined analyses of this published in the archives of American journals and in psychosomatic medicine. And all of the studies, all of the meta-analysis show that hypercortisolism is particularly a sign of delusional depression more so than of depression itself. And this was one of the meta-analyses, that combined analyses that Craig Nelson at UCSF and John Davis showed, Well, they reported 64% non-suppression rate in delusional depressors and about a 40%, 1%. Really, the Mantel-Haensel here is extremely high with a chi-square of about 47. So delusional depression does go with hypercortisolemia. There are two types of receptors in the body for grossly for cortisol. One is a very high affinity receptor. It's called the mineralocorticoid receptor. And it is found primarily in the limbic structures. The agonist is aldosterone. It regulates blood pressure, particularly salt distribution, as well as memory function through the hippocampal MR. And there's a low affinity glucocorticoid receptor that is ubiquitous, found throughout the body, particularly throughout the cortex of the brain. The agonist here is dexamethasone. The antagonist is RU46. That's the French abortifacient agent, mifepristone, that is an abortion drug because progesterone and cortisol have high homology. And almost all the steroids that block cortisol will also block progesterone. Now, we mapped the glucocorticoid and mineralocorticoid receptor in a squirrel monkey model. Paresh Patel and David Lyons and I did this. And we showed from anterior back on coronal sections, you can see enormous amount of glucocorticoid binding message in the cortex. And you see some glucocorticoid binding as well in the hippocampus. Mineralocorticoids are not found that much in the cortex, but found primarily in the hippocampus with stronger binding. But both are found in the hippocampus. Now, psychotic depression, the original observations of Sandy Glassman were built around the fact that these people did not show a response to imipramine, but they also did not show a response to placebo. And they do respond to antidepressants with antipsychotics or to ECT. The Europeans have argued they will respond to atypical antipsychotics or SSRIs alone, particularly SSRIs alone. The American experience has not been very positive with them. ECT, often the treatment of choice, but it has a very high relapse rate, much higher than non-psychotic depression, about 31% versus 22%, in a multi-center study done by the Columbia Group in hospitals around New York City. We were first studied olanzapine fluoxetine combination against olanzapine or placebo. Olanzapine, commonly used antipsychotic. The purpose of the study was to actually show olanzapine monotherapy was an effective antipsychotic and antidepressant in this disorder. And what we showed here was that, in fact, olanzapine fluoxetine combination separated nicely from placebo, and olanzapine alone did not. The label olanzapine fluoxetine was superior to olanzapine alone as well at 0.027. So olanzapine monotherapy did not quite do it. Olanzapine fluoxetine combination did. And the consequence, obviously, with olanzapine is you do show this considerable weight gain, even in an 8-week study, and it has big metabolic effects. Barry Myers has prospectively studied olanzapine and placebo versus olanzapine and sertraline in delusional depression and got nice separation starting at week 2, going out to week 12. The drug, more recently, the combination has been studied to see, do you in fact need to stay on the olanzapine after your initial response at 8 weeks? And you can see here that in a multi-center study published in JAMA a few years ago, sertraline plus placebo was associated with greater relapses quickly after the 8-week randomization, whereas individuals who stayed on olanzapine going out 9 months showed continued improvement. And the probably inflection point is about 6 6 months that you need to stay on the drug. The antipsychotics. The sertraline and olanzapine, the sertraline and placebo, olanzapine again gave you starting weight gain and increases in cholesterol within the 6 months. But within 6 months, it did not necessarily change the glucose or the fasting hemoglobin A1C. So it is, you can probably go 4-6 months with the antipsychotic without, in fact, getting quite to the point of being insulin resistant. Now, we decided to study mifepristone formulated by Roussel and Uclaf. This was originally developed by Etienne Beaulieu, who was head of the French Academy of Science, who was in 95 and was one of the great researchers in neuroendocrine function. It was approved in Europe and Asia in 88, approved in the US in 2000. And again, it's a progesterone receptor antagonist, but when you push the dose, it binds to the glucocorticoid receptor, which is GR2, and it has no affinity for any other receptors. So it's a steroid. Why do we use it? Well, we noticed that the psychotic depressives had elevated cortisol. We showed you those data. And an interesting report that came out of Stephen Lambert's group, who eventually became the rector at the University of Rotterdam, is still a very well-known Cushing's researchers and internists. And he had individuals who had end-stage Cushing's syndrome. The problem with Cushing's disease, a major problem, is that the treatment choice is surgical ablation of the tumor in the pituitary. The problem is that these are usually caused by microadenomas that are not visible directly. And so these patients are often refractory. The treatment then has to be adrenalectomy. The mortality rate within 5 years of untreated Cushing's is 50%. So it's a lethal illness. And he had these individuals who had not only end-stage Cushing's, but they also had developed a psychotic depression, basically. And he found it was difficult to control them with haloperidol. And so he treated them with RU46. And he found rather dramatic improvements in the psychosis of Cushing's disease. And the drug is, and that led us to do a series of studies, initially sponsored by the NIMH and then taken over by Corcept, a company I had co-founded about 25 years ago. And just to give you a sense, in the first study we did, it was a very small double-blind study in about 5 subjects, and we crossed them over after 4 days, and 4 out of the 5 individuals responded to the mifepristone, and only 1 of them responded to placebo. And we then did an NIMH-sponsored study in 30 patients where we treated for a week and looked at response at in this case at 4 weeks, and we found that a 50% decrease in the BPRS was seen in about 50% of the people on mifepristone and about 15% on placebo. When you look at clozapine, for example, as an antipsychotic, the response required for schizophrenia is a 30% decrease at 8 weeks, people treated for 8 weeks. So here we're looking at a 50% decrease at 8 weeks with individuals only requiring to be treated for a week. And the idea was to kind of reset the HPA axis. When you give cortisol, mifepristone, just to give you a sense, there are 4 curves here. The green curve are individuals who have, after they have received mifepristone for a week, and what you see here is that the values and the other values are largely pre-mifepristone or pre and post placebo. You can see here that the individuals have much lower cortisol values than they have if they get mifepristone. Because what happens is mifepristone blocks the feedback to the level of the pituitary and the hypothalamus, and the body reacts by saying, I am being deprived of cortisol, and there's a surge in the release of cortisol. And so you can see in the diurnal rhythm of cortisol, which goes something like from the highest values in the morning at about 9, as you can see here, and the values lower in the evening, but the lowest values occurring at midnight at 2400 hours. And this is the diurnal rhythm of cortisol, but this diurnal rhythm is accentuated by giving mifepristone. So what mifepristone does in part to the H3 axis is block the feedback and re-normalizes the rhythm, and accentuates the rhythm. So we have a nice marker of it. And what we did is we started to do studies for treating for a week, looking at responses at 8 weeks at different doses, 600, 300, and 1200 milligrams. What we found was that when we looked at 3, 6, and 12 milligrams for a week, was that without looking at the blood level, you got a difference in response between drug and placebo numerically, 44% respond versus 34%. But when you added the blood level, the therapeutic cutoff, and we calculated this using ROC curves, 52%, in fact, of the mifepristone people responded. Treated for a week, better at a week, better at 8 weeks, compared to 34%. Interesting in this study, and these people are hospitalized, is notice the placebo response rate. In the original studies of Sandy Glassman 30 years ago, response rates of placebo were 10 to 15% in psychotic depression. So even in psychotic depression, we have these crazily high placebo response rates that have really killed us. And this is a combined analysis we published in Biological Psychiatry a few years ago. And we took the company's 5 placebo-controlled trials, doses of most of them at 600, but one at 3 and 1200. This is 1,400 patients. We looked at response at a week and continued response to 8 weeks. That was the criterion. And you can see here that when we look at the BPRS positive symptom reduction, you can see here no overlap, a highly statistically significant difference if you use the therapeutic blood level. Again, if you get over 1,600 nanograms per ml, you do show a significant improvement in the subjects. In the lower subjects, you do not see particular difference from placebo. So it is dependent on formulating a very high blood level. The problem is that you can't, and this just shows you the response rate, 42% versus 30% versus 30% for placebo. The difficulty with mifepristone is that the pharmacokinetics flatten out at around 1,200 milligrams. So if you go to 1,800 milligrams, you do not get a continued linear response. So you have a sigmoidal relationship. So we have to develop a different kind of compound. Now, we know that if you give mifepristone, you will get higher cortisol levels and higher ACTH levels. And just to show you that even in the lower doses where we get less clinical response, at the lower blood level rather, you show a significant elevation in ACTH compared to placebo. But the higher group, the greater than 1,637 blood level, they show a much higher increase. This is in cortisol as well as in ACTH. So we have a kind of a readout. We have a biological readout of pharmacologic effect at the higher level, not only a clinical effect, but also an effect on both cortisol and ACTH. And when we look at the ITT, the number needed to, the NNTs on anything under 10 is usually an approved or approvable drug. Anything above it, you may get approval depending on the size of the study. The NNT 15. There are a lot of drugs on the market, a lot of anticonvulsants with NNTs around 15. But notice here with the high blood level at 1,637 nanograms per ml, we have an NNT of 7. So, which is extremely low, which means that only you need 7 people, treat 7 people to get one that is going to be better. Separate out in terms of improvement at day 7 as well as day 56, even though you only treat for a week. Problem with the FDA is that they're not really interested in a prospective blood level because they see it as post randomization. And obviously it could be affected by compliance or adherence. In our case, this is not a case for Corcept because the patients are hospitalized, and so we know that the patients have taken the drug. But here you can see the greater than 1,200, that the greater than 1,637 is achieved with more likely achieved at the 1,200 milligrams per day dose. You get lower response rates, the lower achieving of the blood level, and with the lower doses. So you do have to get at least to 1,200. But the sigmoidal relationship is going to limit that until we have a better penetrating drug into the CNS. So, just in summary, anxious depression, we're seeing it more and more interest in it, because antidepressants alone are not particularly effective in STAR-D and iSpot. Adding an antipsychotic, adding a benzodiazepine or other sedative hypnotic, it seems to be helpful, and potentially the neurosteroids. And for the psychotic depression group, we're dealing with ECT and combination of antipsychotics and antidepressants, but eventually, hopefully, perhaps a very specific treatment using glucocorticoid receptor antagonist. So thank you very, very much, Maurice, for the opportunity to speak, and I'm glad to answer any questions. Thank you.